Educational and powerful presentation. Now it's your turn to ask questions of Dr. Ehlinger and a handful of other health equity leaders who have joined us today, including Dr. Nalo Johnson and Chris Mackey. The Q&A will be moderated by Amy Bentley, Policy Director of the Harkin Institute. Dr. Nalo Johnson is the Division Director for Health Promotion and Chronic Disease Prevention at the Iowa Department of Public Health, where she oversees 4 bureaus: Chronic Disease Prevention and Management, Family Health, Nutrition and Physical Activity, and Oral Health, along with the Office of Disability, Injury and Violence Prevention. Dr. Johnson has extensive experience in public health and community health efforts at state and local levels in both chronic disease prevention and health promotion, as well as communicable disease prevention. Dr. Johnson has a specific interest in reducing health disparities among Iowa's vulnerable and underserved populations. Chris Mackey has more than 20 years of experience in the field of disability and health. He currently is a senior project coordinator with the National Center on Health, Physical Activity, and Disability at the Lakeshore Foundation in Birmingham, Alabama. He serves as lead staff member in NCHPAD's activities in the public health sector, which include initiatives related to inclusive health, healthy community design, accessibility of health promotion environments, adapting evidence-based chronic disease prevention and management programs, particularly in the area of diabetes, and health equity for people with disabilities. You can submit your questions for the group in the chat box.
Thanks, Lindy, for the introduction, and thank you to all of our panelists for being here today. I also want to say a special welcome to Senator Harkin, who I believe is able to join us by phone today. Senator, are you able to hear us?
I'm hearing you. I don't know if you hear me.
We can. Welcome. We're very glad that you can be here. Would you like to start us off on our panel here and talk some about, just over your career and experience, what are some of the biggest challenges to addressing health equity today that you have experienced?
Well, I think over my career, the biggest inequity, the biggest stumbling block towards equity in healthcare, and especially in the area of wellness and prevention, is income status. And closely aligned with that is certainly racial status. The systemic racism that we have had in our society for so long has worked to keep people of color from participating in the kind of prevention and wellness programs that upper income, mainly white Americans, have been privileged to participate in. I think that our public health
We might have lost the senator, but while he gets back on, we'll move on. Building off of the senator's comments on systemic racism, one of the events the Harkin Institute will be hosting on April 8th is a conversation with Nicole Hannah-Jones, who started the 1619 Project with the New York Times Magazine, which has really sparked this national conversation on reframing our shared history to address racial bias. And I'd be interested to hear from some of our panelists, thinking along those same lines of reframing and rethinking how we share and live our experience, how that impacts your work and the work that you do. And I wonder, Dr. Johnson, if you might want to start on that line of thinking.
Sure, thank you. So, in thinking about how we're focused on disparities within the field of public health, I really understand public health as a tool to create and maintain healthy communities. So when it's practiced to its fullest extent, I believe that public health can provide us with a data-driven framework to understand where health disparities exist in our community, to help us identify in collaboration with community members, much to Dr. Ehlinger's point in his presentation, what type of solutions we should be considering, and also being able to track those outcomes so that we can ensure we are seeing health improvements. So to provide a tangible example of that type of work, looking at our state's maternal health data, we find that the greatest maternal health disparities exist for Black women in Iowa. And thus we are currently designing an intervention where we will provide culturally congruent community-based doulas as a service offering in some of our Title V health clinics. And we will track those outcomes to see if this intervention is helping reduce the maternal health disparities in the state. So while piloting a project that is specific to Black women may be a bold strategy, we feel that this data can help us understand if the intervention works, and then have the opportunity to expand that to all of our Title V participants as well. And again, in order to see the better population health outcomes across the state, we know that we need to be very explicit about reducing the health disparities that exist within our population.
Thank you, Dr. Johnson. And then moving the same question to you, Mr. Mackey, but really looking and adding that social identity of disability and how that impacts the same situations, that the racial disparities, and kind of layering on those multi-identities and what that means.
Sure. And thank you for having me. So for just some background, what I do, what the National Center on Health, Physical Activity, and Disability does is really work from a public health perspective to reduce the health disparities that people with disabilities experience. And when we say disabilities, we're talking about the spectrum: people with physical disabilities, intellectual disabilities, sensory disabilities. And what we know and have known for a very long time is that people with disabilities experience even higher rates of disparity in health status compared to people without disabilities. We know that people with disabilities have higher rates of poverty. We have higher rates of obesity, higher rates of 2 to 3 times higher rate of stroke and cancer and diabetes. And so this is obviously a very critical and serious public health problem that we are trying to address. And people with disabilities are a demographic, and I think that's an important point to make. But we're a demographic that is often overlooked in terms of public health practice. But sort of at the core of what we do is of course the idea of inclusion, and including people with disabilities in meaningful ways in health promotion and public health practice and health promotion practice, and really reframing, which I think is definitely applicable to the 1619 project and those articles, reframing the word and the idea of disability, and really looking at disability from the standpoint of what we call the social model of disability, which typically when we think of disability, it's the medical model, which is a disability is internal and intrinsic to the person. And so the reason why Chris, myself, who has spina bifida, can't be healthy is because of his spina bifida. But the social model of disability says that I can't be healthy because the doctor's office is not accessible, the fitness gym is not accessible, the farmer's market that is in my community I can't get to. There's not only is there no transportation, there's no accessible transportation. So when you have people with disabilities, we experience, and I'm a wheelchair user myself, we experience an added layer of disparity and barrier. That is even multiplied when you are an individual who is multiply marginalized. So African Americans with disabilities, people from the LGBTQ plus community with disabilities all experience even greater levels of disparity. And so what we do is really look at how do we transform communities so that everyone has an opportunity to be healthy, and really looking at barriers, to access that often are the same as everyone else. So cost of healthcare, cost of health promotion, transportation. Those are all barriers that I think people of marginalized groups face across the board. But when you add disability, it's about even more access. So accessible transportation, not just transportation, accessible healthcare, not just having it there, but can I actually get in the door? And so what we do is really work to build the capacity of health promotion providers such as public health, education, healthcare providers to be more inclusive of people with disabilities. And our work in particular really leans towards promoting access to physical activity and nutrition. And so that's kind of where our name comes from. We're actually funded by the CDC and one of 2 centers that focus on disability and disparity. And so, that's kind of how our work is oriented. It's really about reframing what we think of disability. So that's my kind of thoughts for that.
Thank you for those comments, and we're so excited that you're here. One of the things that Senator Harkin has challenged us at the Institute with is to find a way to bring disability and some of those other marginalized conversations into all of our programming, and this has just been a wonderful connection, and we're very happy that we can make it and hope to continue to work with you and your center and bring all of those conversations together moving forward. So changing directions a little bit, and Dr. Ehlinger, I think it'd be great for you to start with this. In addressing the social determinants of health, could you talk some to working across systems, and particularly with federal, state, local partners, community-based programming, just kind of the importance of that and how you do it? And then we also have mixed in with that one of our participant questions, which is, can you talk some about how those federal systems have changed since the 1970s through the 80s and 90s, when we saw, coming out of the civil rights movement and the disability rights movement, more of a focus on health?
Well, yeah, I'd be pleased to answer that question. But first, I want to comment a little bit about what Dr. Johnson and Mr. Mackey mentioned, because I was talking about doulas. Doulas have been shown to be a way of reducing disparities, reducing inequity, and yet we don't pay for them. And so, and this is because we put all of our money more into the high-tech medical care and not into the support services. So we need to find ways to have doulas be a profession that you can actually make a living in, and particularly women of color who can be doulas. So that's one of the things I'm trying to do with the Secretary's Advisory Committee on Infant Mortality. And the other thing, in terms of disabilities, when the Children's Bureau got started in 1912, the focus was on quote unquote handicapped children. And it said, because it shows that if we do things for people with handicaps, everybody benefits. And certainly one of our senators, Paul Wellstone, said, we all do better when we all do better. And as I mentioned in my speech, equity is actually benefits all of us. We all have vested interest. We all do better when we all do better. And when we can actually get people with disabilities, whatever those might be, engaged in a meaningful way, we all do better. It is not a zero-sum game. So, but back to the question that you asked, how do you work across systems? I think you need to purposefully do some outreach to other systems. When I was health commissioner in Minnesota, I purposely went to all of the other commissioners and all the other agencies to have them talk about their role in health. And most of them said, well, I don't have a role in health. I get buses and trains and I do insurance regulation. But when we started talking, they all of a sudden realized they have a lot to do with health, and they have a lot to do with health equity. And it actually helped change how they thought about what they did. And I always got pushback, well, aren't you in their swim lane? And I realized, I'm responsible for the pool, not any particular swim lane. And other people in other agencies really wanted the health sector to be part of their work because they wanted the partnerships. So they, saw us as good partners. And so you need to do active outreach into other communities and let them take credit for the work that they're doing. I love the fact that the transportation department changed its motto from, trying to move people to actually placemaking. The transportation department changed their vision as a placemaking agency as opposed to a people moving agency. So it is a partnership, and you have to build on that partnership. The referral to what changed after the 1960s. One thing, this is where the structural racism comes in. Communities of color in the 60s were building power. They were getting control over what was happening in their communities, and that threatened a lot of other people. So many of the policies that came following that really undercut the building of power that was happening in communities throughout the country, particularly in communities of color. It also came right around and I'll be a little partisan here, when Ronald Reagan got elected in 1980 and started working on 81, the shift of money away from public health, the maternal and child health was cut by 25% in the block grant. And that had a huge impact, immediate impact on the kind of services that were delivered and the approach that was being taken by health departments. And the money then got shifted over into more on the medical care side. And as I said in my talk, medical care is overwhelming how we spend our money. We're taking money away from places where it really works, and these are policy decisions. Similarly, when I moved to Minnesota in 1980, we didn't have homeless shelters. We didn't have food banks. Yes, there were some people who had some food insecurity, nutrition insecurity, and housing insecurity, but it wasn't like we're having today. And so policy changes that were made in the early 80s immediately put people on the streets, immediately made people nutrition and food insecure. And that has persisted for the last 40 years, which we thought was going to be a temporary thing. Policy changes that were made at that point in time are perpetuated to today. And so for us to change those policies is going to take a lot of work, take a lot of partners, and that's where we need to build again the community power. That's what I really like about the social justice protests that are going on. Communities are actually, multiracial communities are coming together to build the power in their community to make change.
Thank you for those comments. Dr. Johnson, can you identify with that metaphor of staying in your swim lane and an expectation of a difficulty of, getting out of those silos, and how do you navigate that at the state level?
Yeah, I'd actually just like to build on what Dr. Ehlinger shared in terms of that kind of cross-sector engagement. I'm a strong believer in the community wealth model. So that idea of your private, your public, your nonprofit, and your philanthropic partnership in order to address a community health need. And I think that's really important because each sector has their own expertise as well as their own resources to bring in the table or to the table, whether that's from a policy standpoint and what you control, or whether that's from a budgetary standpoint and what you can provide. So I think it's really important that we think broadly when we're attempting to address the community health need so that you can have the broad, expansive set of resources and expertise in order to problem solve. I think it's also important to acknowledge the key role that being in conversation with community members themselves plays in order to really holistically identify what kind of solutions or interventions you should be considering. So I also believe in that concept of nothing about us without us, right? Like inevitably you're going to miss something if you aren't talking to people who are experiencing the phenomena themselves. So again, to speak to the doula project, we worked with maternal health birthing professionals within the state in order to build that intervention. So specifically working with the Iowa Black Doula Collective, as well as Black certified nurse midwives at the University of Iowa hospitals and clinics, and being in conversation with them while we at the public health department had the quantitative data to be able to talk about what the picture of health is in the community. Being in conversation with our Black maternal health birthing professionals really helped give us a full understanding of what best practices we needed to be considering when we designed this project. And I think that's what will really help it be successful as well.
Thank you. Mr. Mackey, continuing on the same conversation, the concept of nothing about us without us is definitely prevalent within the disability community, and you're set up to be a resource really for anyone that is wanting to access that. Are there certain hurdles or roadblocks, or what do you think are the things that might prevent an organization or group or a city or anyone from accessing your services or outreach? What are you seeing?
Well, I think as far as what we do, we're federally funded, and we work. The work that we do is available to the resources that we develop are available to people and communities at any point. We're really an online resource, but I think one of the biggest barriers is that people with disabilities, again, kind of thinking from the public health perspective, one of the things we say is that disability is a demographic and not a health outcome. We're talking about a group of people. And so I think there needs to be greater recognition of people with disabilities as a demographic with specific health needs. I think a number of barriers exist across the board, across all systems. And really what we look at is not just PSE, policy systems environment, we look at programs, policy systems and environments. And really, how do we change all of those aspects of health and wellness to create healthy communities? I think many different barriers exist, starting with pre-professional training. As we kind of alluded to earlier, different health promotion professions don't get training in disability. I think one of the biggest sort of barriers is that there's not enough information and education and compliance with disability rights laws. We just had the 30th anniversary of the ADA, and even over the years, even within the disability community, there's been efforts to roll back some of the rights that were guaranteed under the ADA. So I think, and then, there's misconceptions about what the ADA and other disability laws are requiring people to do. And so I think, that's a barrier. I think just, the inaccessible environments, really looking at the idea of and focusing on universal design. I think that is really should be the ultimate goal when you're trying to access and include people with disabilities, is really how do we create environments and programs and policies and systems and communities that are open to everyone. And there are ways to do that. And the laws that we have in place are really just the starting point. What we're really aiming for and what every community should be aiming for in terms of health is inclusion.
Thank you for that. So I think, Dr. Ehlinger, you might be good to start this next round of questions. I don't think it's a secret that many people are a bit disillusioned with our institutions right now today. And so at an individual level, like recognizing that large structural change might be what is necessary and needed, perhaps isn't going to happen right and immediately. So on an individual level, what would you suggest for something we all can do, whether you're in public health or not, to create change or movement?
Well, I believe that health is not an individual activity, it's a community activity. And so it's hard to do things just by yourself. You need partners. And so we need, first of all, develop some partnerships, develop some relationships, because that's where you start building the power. Or join with other people. The idea that when someone starts, it's usually the second person that jumps in and joins that's actually more influential in making decisions, because people sitting on the outside saying, that person is really weird trying to do this individual thing. But then when they get a partner, they say, oh, well, somebody else is joining that person. So reach out, join together, form partnerships, and always form partnerships with the idea of building capacity. If we're not building community capacity, we're not doing our work properly. Just by having a relationship that I get something out of it is not worth doing. How can I increase? Yes, I have some vested interest. I want to build my, what I get out of it, but I also want you to get a lot out of it. I want to build your capacity. And then from there we spread out. So start small, think small, but know that it's gonna grow by building partnerships, building capacity, and that'll actually change how things go.
Dr. Johnson, do you have any thoughts to add? What can someone do as an individual, whether they're in the public health field or not, to create action and movement and be helpful?
I think it's important for people to have a clear understanding of what we mean by health equity, and that having an awareness of achieving health equity is a first step. But to Dr. Ehlinger's point, operationalization of that effort is really where we need to get, because our goal around health equity is that we're going to see better population health outcomes, right? And I think it's important for people to recognize that doesn't just have to occur at a program level, that we also need to be thinking about the policy impacts as well, because those policy impacts are not only impactful, but they have those long-term consequences. So they can have long-term negative effects, they could have long-term positive effects as well. I think, so I'm sticking with my theme here because I think tangible examples are important. So again, as part of that doula project, obviously we're seeking to see improved maternal health outcomes amongst our African-American birthing population. Yes, but part of the goal in tracking that health outcomes data is to be able to create an ROI to convince insurers to consider the reimbursement of doula services. So that outcome is a policy-driven systems change outcome that is directly related to health equity work. So I think just remembering that those policy touch points around a health equity focus are just as critical and important as the programmatic or individual health outcomes as well.
I want to jump in for just a second and highlight the fact that one of the things you can do is challenge the common narrative about what creates health. And Nalo is doing that. It is not about individuals, it's about community. So challenge the narrative. We need to change the narrative. We need to change the public sentiment, as Lincoln said. So that's part of that in building relationship, to change the narrative about what creates health.
Mr. Mackey, I want to go back to something you said earlier, which was hitting on that concept of universal design, accessibility, inclusion, and that's something we've worked on over the last year in working with the design team to put a new building together for the Institute and trying to be a showcase of inclusion and universal design. Something they've found and we've shared is that those same practices also have been really helpful in a COVID-19 world of having a healthy work environment. And so I'm wondering if you might speak a little to, have you found other connections as people are trying to address this public health crisis, where you can share and say, well, these are things we've already been doing and here's kind of a dual purpose of why we do them?
I think the disability community has been saying since the pandemic started, this, all of these modifications that we're all experiencing, like working from home and doing virtual meetings, those have been accommodations that the disability community has been shouting for years. So I think that is one sort of aspect of the current pandemic that people with disabilities are hopefully benefiting will continue to benefit from. But I also think what we're seeing with the pandemic is another example of how disability and people with disabilities is getting left out of the conversation. When we talk about access to, well, there's so many issues that are at the core of how the pandemic and any kind of public health issues are affecting people with disabilities. When we were talking, we do a little bit with our local health department and local disability advocates around addressing issues that are experienced by people with disabilities during the pandemic. And one of the biggest problems was early on the lack of access to testing and lack of transportation, the issues that people who have personal care attendants and rely on other people and cannot socially distance because they have to interact closely with individuals. I think that was an example that was not taken into consideration when guidance was given for how to keep yourself safe for during the pandemic. Now we're talking about vaccines and how do we get people who don't have transportation and only use public transportation that has to be accessible. How do they get to vaccine sites? There's so many issues that pop up. Food insecurity again is becoming a huge problem for everyone, but in particular for people with disabilities who may again rely on someone else to do shopping, to do cooking, to do all manner of health promotion, access to healthy food. So those as we see with other health issues, communities are not prepared to address the needs of people with disabilities during the pandemic.
So we have time for one last round of questions and your answers. So I'm wondering kind of what are your closing thoughts? What's one thing you hope people take away from our discussion about health equity today? And Dr. Johnson, would you be comfortable starting us on that?
Sure. So I think that it's important for people to recognize that health equity is not synonymous with diversity and inclusion. And I think that people often conflate those concepts, and folks can have an engagement with and a support for diversity and inclusion and understand that those concepts are vitally important and connected to equity, but it's not health equity in and of itself. Health equity seeks to address systems that create negative health outcomes within the community. And an application of a health equity lens really allows us to address these systems through a data-driven effort to reduce disparities within our community. So I think, again, speaking to some of my earlier comments, it's really important to recognize that the application of a health equity lens is not owned by the public health sector alone, that work can occur across sectors, and particularly when we're taking that social determinants of health approach and you're thinking about potential program or policy changes to address disparate outcomes within the community, being able to apply that health equity lens is really critical, regardless of the sector.
Mr. Mackey, would you be ready to go next?
Sure, yeah. I think, well, there's a quote that I like from a woman who is African-American. Her name is Haben Girma, and she is the first deafblind graduate of Harvard Law School, and in the mid 2010s. And one of the things that she says, she goes around and does a lot of speaking about disability inclusion and disparities and racism and disability. And one of the things that she says is that disability is an opportunity for innovation. And I think when you are really purposefully and actively focused on inclusion of people with disabilities, what you come up with are solutions that really work for everyone, at least in terms of ability level. Because people with disabilities, we spend our lives sort of trying to come up with solutions to navigate different environments that weren't conceived with us in mind. And so I think to kind of reiterate what everyone was saying earlier, that disability, or excuse me, that inclusion happens when you partner with people with disabilities. And then when you do that, you come up with some innovative solutions that work for everyone, or can work for everyone if you do it right. So I would say, again, just reach out. Partnership is key to really creating communities that support the health of everybody.
Thank you so much. And Dr. Ehlinger, you brought us into this segment with your keynote. So and you can take us out. What is your one thought, your one final takeaway that you'd like us all to have?
Well, I'm following up on these two other panelists here about, equity is not just about diversity and inclusion, which it does include, but it is about everybody having the opportunity to thrive. And everybody means that it is not somebody else's problem. It is our problem. It is our collective problem. It is our collective issue. As I said in my speech, inequities are an existential issue. They're going to change society if we don't deal with them collectively. And it gets back to the Institute of Medicine definition of public health. Public health is what we collectively do as a society to assure the conditions in which people can be healthy. It means everybody, all sectors of society, those who are rich, those who are poor, those who are black, those who are white, and everything in between, people with fully able and those people with some limited abilities, physical abilities. All of us collectively have to assure the conditions, and those conditions, yes, they include medical care and science and technology, but they include housing and transportation and public policy and art and music and dance. They include all of those things. So we need to have a broader definition of what creates health, and we have to recognize that we all have a role to play. We are all responsible to forming partnerships to create the conditions in which everybody can be healthy.
Thank you so much, and thank all of our panelists for the discussion today. I know I've enjoyed it, and I hope all of our viewers have as well. Thank you for your time. We'll transition now. We're going to hear a message from our platinum sponsor, Sukup Manufacturing.